Thanks, Amy. It is great to be here despite the loss on Saturday. I had the privilege of staying at the Michigan League last night, and the hotel room the room they put me in overlooked right at the bell tower. And I remember many years as a student here passing that as I was going to study at Rackham. So it was a real privilege to stay there. So as was mentioned, my role is to help set the context for the day. Specifically, I'm going to share with you the latest data on the public health burden of prescription drug overdoses and heroin. I don't have to tell you that we're in the midst of an opioid epidemic, driven largely by the overprescribing of opioid pain relievers in the treatment of chronic pain. More recently, the sharp rise in heroin-related overdose death is a new and frankly not entirely unrelated development in an epidemic that is hitting every corner of our country. And we're seeing new challenges like heroin laced with fentanyl and collateral impacts like neonatal abstinence syndrome in newborns and hotspots of HIV and Hep C, all associated with opioid use. So my remarks, as you'd expect from somebody from CDC, are filled with graphs highlighting data from our present reality. However, I wanted to start by calling attention to society's complicated relationship with the morphine molecule, a history that dates back to 4000 BC. These two books, Drugged by Richard Miller and Dreamland by Sam Quinones, really do a masterful job of telling about how we got to now. Drug is more technical and outlines the origin, development, and use of natural and man-made opiates, including its proliferate medicinal use as a cough, cold, and pain remedy in the 18th and 19th centuries. It was also used, by the way, as a children's sleep aid at the time. Its medicinal use was so common during the U.S. Civil War that drug-addicted veterans referred to it as soldier's disease. Dreamland is more contemporary and outlines the confluence of factors leading to the current epidemic, including, as has already been mentioned, pain being designated the fifth vital sign, an underappreciation of the addictive potential of prescription opioids, aggressive marketing of these drugs to clinicians, rogue actions by clinicians who ran pill mills that profited from overprescribing, and sophisticated actions of Mexican drug traffickers to open new black tar heroin markets that made it as easy to get heroin as it was to order a pizza. So what do we know now? Well, more than 145,000 people have died from overdoses involving prescription opioids in the last decade, and deaths have quadrupled since 1999. While opioid pain relievers can and certainly do play an important role in the management of some types of pain, the overprescribing of these very powerful drugs got us into this problem. Sometimes a picture tells a story better than words, and this is certainly true in this epidemic. This is a time series map showing state-based drug overdose mortality rates shifting between 1999 and 2010. Prescription drug overdoses are among the few causes of death that are on the rise, and the trends, as you can see here in the darkening red on the map, are pretty stark. Every state has seen dramatic increases in mortality rates, with some states in Appalachia and the Southwest being particularly hard hit. Opioid pain relievers such as oxycodone, hydrocodone, and methadone are responsible for driving the epidemic. The yellow line shows the fourfold increase in deaths since 1999. In 2013, over 16,000 people died from a prescription opioid overdose, or about one death in every 33 minutes. Among all drug overdose deaths that year, approximately 37% involved prescription opioids, and another 19% involved heroin. So 3 out of 5 drug overdose deaths that year involved an opiate. Benzodiazepines like Valium and Xanax were involved in 30% of opioid pain reliever deaths in 2013, and this is up from 13% in 1999. By the way, notice the slight plateauing in the yellow line in recent years. Beginning in 2012, deaths dropped for the first time since the 90s. Nearly 1,000 fewer people died from a prescription opiate in 2012 compared to the year before. But that said, the data showcase with the blue line another troubling trend, the recent, frankly, alarming increase in heroin-related overdose deaths, and I'll talk a little bit more about that later in my presentation. You probably saw this in the media several weeks ago. The health impacts of prescription drug and heroin use are beginning to impact overall mortality for middle-aged white Americans. This recent paper by Deaton and Case showed that mortality rates for whites, 45 to 54, with no more than a high school education, increased by 134 deaths per 100,000 people between 1999 and 2014. This is a jump in the death rate of around 20%. This trend is an anomaly. No other age group, no other racial or ethnic group, and no counterparts in other high-income countries are seeing death rates rise in the same way. Only the HIV/AIDS epidemic provides a contemporary example with similar devastating consequences. But I will say, since its release, critics have called into question some of the methods used by Deaton and Case, most notably their lack of age adjustment, suggesting instead that the increase in mortality rate is a statistical artifact of the aging U.S. population. But that said, even after you do age adjustment, the increase does not entirely go away, especially from the age groups 47 to 52. So even if you cede some of the argument and ratchet down the observed increase to be more modest, death rates for middle-aged people in countries like the United Kingdom fell by almost a third between 1999 and 2013. And here in the U.S., death rates for Hispanics and blacks followed a similar pattern. But middle-aged white Americans didn't share in these gains, and prescription drugs and heroin are partly to blame. So when you look at the total impact of opioid use, really a staggering number of Americans are impacted. In 2011, for every one overdose death involving opioids, there were 12 substance abuse treatment admissions, 25 emergency department visits for misuse or abuse, 105 people who met criteria for abuse or dependence on opioids, and 659 people, 12 and older, who reported using opioids non-medically. And equally staggering, for every one overdose death, America incurs an estimated $4.3 million in health-related costs as you go down this cascade. $250 million, this is, every time I say this statistic, it's staggering to me. Providers wrote more than $250 million opioid prescriptions in 2012. That's enough for every American adult, all of us assembled here, and the 240 million other American adults 18 and older, to have our own bottle of pills. This is twice as many painkiller prescriptions per person compared to our neighbors in the North and Canada. Dr. Desmond showed this map. I want to put a finer point on it. There is wide state-to-state variation in prescribing. Healthcare providers in the highest prescribing state, Alabama, wrote almost 3 times as many of these prescriptions per person as those in the lowest prescribing state, Hawaii. On a drug-by-drug basis, the variation is even more pronounced. Nearly 22 times as many prescriptions were written for oxymorphone in Tennessee than in Minnesota. As you can see, most of the highest prescribing states were in the South, and state variation was greatest for long-acting or extended-release opioids and for high-dose formulations. And I need to also mention that earlier studies suggest that regional variation in the use of prescriptions cannot be explained by the underlying health status of the population. So one driver of the increase in opioid overdose deaths is the abundance of supply of these very powerful drugs. This graph shows the relationship between the sales of opioids, the green line, and the number of deaths from them, the blue line. As you can see, the amount of opioids sold increased, so too did the number of deaths. They increased really in lockstep with one another. The supply of opioid pain relievers is larger than ever, and the quantity sold in 2011 was 4 times that sold in 1999. Do notice the slight plateauing and the decrease in prescribing in 2013, and this does correspond with the slight decrease in deaths that I showed you earlier. So as you saw earlier, there is wide state variation in overdose death rates. In this case, the darker the shade of blue, the worse the rate. Overdose death rates in 2013 ranged from 2.8 per 100,000 in North Dakota to 32.2 in West Virginia, an 11-fold variation. What is unique about this figure is that we overlaid the opioid pain reliever sales rates on the map. The sales figures are the yellow bubbles. The larger the bubble, the greater the sales. While not perfect, note how states with the highest death rates also tend to have the highest sales rates. In 2013, national drug overdose death rate of 13.8 per 100,000 was, if in 2013 the national drug overdose death rate of 13.8 per 100,000 was reduced to the lowest state-based rate in North Dakota, almost 9,000 more Americans would have been alive in that year alone. So when you juxtapose 2 regions of the country, the upper Midwest and Appalachia, the differences, frankly, just jump out at you. All 5 of the states in the upper Midwest, North and South Dakota, Nebraska, Minnesota, and Iowa, have among the lowest state-based drug overdose death rates in the country. They also have very low prescribing, as you can see. On the other hand, West Virginia and Kentucky have the two highest drug overdose rates, and Ohio, Pennsylvania, and Tennessee are in the top 12. Also note how their corresponding sales rates are high too. Beginning in 2012, FDA, CDC, the Bureau of Justice Assistance, and the Brandeis Center of Excellence on PDMPs collaborated to use PDMP data for public health surveillance. We created a system called the Prescription Behavioral Surveillance System, or PBSS. The main goal of PBSS is to create an early warning surveillance and evaluation tool. PBSS uses standard metrics to measure prescribing rates by demographic variables, drug type, daily dose, and source of payment. States can spot patterns that they could never have seen using just their own state's PDMP. A few weeks ago, we released our first PBSS report using data from 8 states that corresponds to about 1/4 of the U.S. population. This graph is pulled from that report. Opioids were prescribed at higher rates than stimulants or benzodiazepines in all states, and we're approaching 1 prescription per state resident in 3 states. Prescribing rates by drug class vary widely by state, almost twofold for opioids, almost 5-fold for stimulants, and almost 2-fold for benzodiazepines. Louisiana had the highest rate, and California had the lowest rate for all drug classes. Also from PBSS, opioid prescribing rates increased steadily with age in California and Idaho. However, prescribing rates peaked in either the 45 to 54 or 55 to 64 age group in the other 6 states. And notice how this corresponds with the highest at-risk groups. So multiple studies have shown that a small fraction of prescribers really write the majority of opioid prescriptions. Known as the Pareto principle, or the law of the vital few, this understanding can help us target our prevention efforts, at least in part, to this small number of prescribers who are really catalyzing the problem. For example, in this study by the California's Worker Compensation Institute in 2011, they found that 3% of prescribers, or about 279 clinicians in this study, were responsible for 55% of Schedule II controlled substance prescriptions, 62% of all morphine milligram equivalents, and 65% of payments between 1993 and 2009. And by the way, these high-volume prescribers are often more likely to have previous actions against their license, write a prescription that is implicated in an overdose death, and have patients in their practice who doctor shop. And this is an anomaly pulling from the PBSS study I just showed you. The top 10% of prescribers wrote half or more of the opioid prescriptions in all 8 of those states surveyed. And in Delaware, this top 10% wrote 2/3 of all opioid scripts. So which clinician specialties are prescribing the most opioid pain relievers? Well, the answer to that question really depends upon how you ask the question. The CHOP chart with the blue columns shows overall numbers of opioid prescriptions by specialty. Here, family practice, internists, and general practitioners provide the largest number of opioid prescriptions, or over 120 million prescriptions for these 3 specialties alone. And notice in the graph that PAs and nurse practitioners also write a lot of scripts. The bottom chart with the red columns shows that opioid prescribing rates as a percentage of medications prescribed. And not surprisingly, pain specialists, surgeons, rehab specialists, and dentists prescribe opioids at the highest rate. Why the difference between the two? Well, obviously there are so many more primary care clinicians when compared to those in other specialties. And so with more prescribers, the total number of prescriptions add up. And later on this afternoon, I'll get a chance to talk to you a little bit more about some of the work the CDC is doing in releasing opioid prescribing guidelines for primary care practitioners for chronic non-cancer and non-end-of-life care. We hope to release those in January of next year. So one more note about why both opioid prescribing and opioid-related overdose deaths have increased during the last couple of decades. In the early 90s, opioid pain relievers were used primarily to treat pain at the end of life and for acute pain. But by 2010, among the most frequent indications for opioids, chronic non-cancer pain accounted for half of the U.S. opioid market, shown in the gray and black areas on the chart here. This includes conditions such as fibromyalgia, osteoarthritis, rheumatoid arthritis, and low back pain. And as has been highlighted in the 2014 AHRQ systematic review, The evidence of the effectiveness of long-term opioid therapy for chronic pain conditions like this is frankly very, very limited, and the risks may outweigh the benefits, especially as dose increases. So who's at greatest risk? Rates of opioid use and overdose death are highest among men, people in their working years of life, and non-Hispanic whites. Poor and rural populations are in general more likely to experience prescription overdoses too. People who have a mental illness or a co-occurring non-opioid substance use issue are overrepresented both in those using them non-medically and those dying from them as well. This is from Amy Bonnert's great work. As dose goes up, risk goes up, both when opioids are taken for acute and chronic pain. Following a case cohort design and using a large sample from the VA, Amy and her colleagues showed that among patients receiving opioid prescriptions for pain, higher opioid doses were associated with increased risk of opioid overdose death. So for patients on a maximum prescribed daily dose above 100 morphine milligram equivalents, or MME, there was a 7-fold increase in death. And even for patients in the range of 50 to 100, the risk was almost 5-fold. As we've learned more about these risks, existing evidence-based prescribing guidelines have continued to lower the cautionary MME dose from 200 to 120 to 100 to even lower. Eric Klapovich and colleagues, one of whom Tara Gomes, who you'll hear from later today, recently published an excellent cohort study using data from over 285,000 individuals in Ontario, Canada. Over 32,000 patients were on chronic opioid therapy. This is taking an opioid for 3 months or longer between 1997 and 2010. They found that 1 out of 55 patients on chronic opioid therapy were escalated to doses of greater than 200 MME, and that 1 out of every 550 died of opioid-related causes at a median of 2.6 years from their first opioid prescription. And not surprisingly, risk was dramatically higher among patients escalated to higher doses of opioid therapy. Among those taking greater than 200 MME, 1 out of every 33 died from opioid-related causes, and men were more likely than women to both escalate to a higher dose and to die from opioid-related causes. The relationship between dose and overdose was further elucidated by Baumblatt and colleagues studying data from Vital Statistics and the Tennessee Prescription Drug Monitoring Program. They also underscored that doctor shopping and pharmacy shopping are a marker of risk too. Using a matched case control study, they found that the risk of death from an overdose went up 6-fold for decedents who had visited 4 or more doctors or used 4 or more pharmacies. Risk was 11 times greater for patients on greater than 100 MME. Patients with 1 or more risk factor, doctor shopping, pharmacy shopping, or a high morphine milligram equivalent accounted for 55% of all overdose deaths. And strikingly, they also documented that 2 million Tennesseans, or about 1/3 of the state's population, fill an opioid prescription every year. Methadone is a particularly problematic opioid used for pain when it's used for pain treatment. While it's attractive because of its relatively low cost, it's 1/18 the cost of the next cheapest opioid. It really does have a number of disadvantages. These include challenging pharmacokinetics, whereby the analgesic benefits wear off well before its half-life in your body, potentially leading to severe respiratory depression and death. Methadone is involved in 30% of opioid-related deaths, even though it accounts for only 2% of opioid pain prescriptions. This amounts to about 5,000 deaths per year. This graph shows that the methadone-related death rate when only a single opioid involved is over double morphine, and the gap is even wider when you look at other opioids. So one of the central premises leading to the proliferate use of prescription opioids was the argument that if used properly, they would not lead to addiction. And work by Edlin and colleagues has really helped to debunk this myth, especially when a high daily dose is taken for greater than 90 days. Using data from a large medical claims database, they showed that patients on a long duration and high-dose opioid prescription or over 90 days at a greater than 120 MME had a 122-fold increase in the likelihood of being diagnosed with an opioid use disorder. Even at lower doses of 36 MME or lower, there was a 15-fold increase. So among the striking features of this opioid epidemic are, as I mentioned at the onset of my presentation, some of the collateral health impacts. The story of the current HIV and Hep C outbreak in Austin, a rural town of 4,200 people in Scott County, Indiana, exemplifies these unintended consequences. And by the way, Austin is much like any town USA. In late March, Indiana Governor Mike Pence issued a public health emergency order in response to an emerging outbreak of HIV cases. They've documented over 180 cases of HIV, and approximately 95% of those cases are co-infected with Hep C. And so to place this in context, there were only 21 cases of confirmed HIV in this community prior to December of 2014. So they jumped from 21 cases to 180 in this year alone. Almost all persons identified in the outbreak injected Opana ER, or the generic version, in the last 6 months, with daily injections occurring between 4 and 15 times. Case reports also indicate up to 6 injection partners per event. Roughly 10% of the population of Austin, Indiana, 10% are injection drug users. So beyond treating the HIV and Hep C, local, state, and federal agencies are also working to increase access to needle exchange programs and medication-assisted treatment. Fortunately, the pace of new HIV and Hep C cases is beginning to decline, but this really does beg the question. We've had a lot of conversations internal at CDC about what other communities might be at risk. So another troubling trend of the opioid epidemic is the increase in neonatal abstinence, or babies born addicted to opioids. There's been a significant increase in the incidence of NAS. Schumacher and Bennyworth documented that the NAS birth rate increased nationally 225% from 1.2 to 3.4 per 1,000 hospitalized births between 2000 and 2009. And stated differently, this means that there were approximately 13,000 infants diagnosed with NAS in 2009. That's one infant born every hour in the U.S. had some form of drug withdrawal. The rise in NAS deaths coincides with a nearly 5-fold increase in mothers being dependent on opioids during the same time period. And state-specific data, in this case, are even more troubling. Tennessee saw a 10-fold increase in NAS cases since 1999 to 8.5 per 1,000 live births, and Kentucky saw an 11-fold increase in the same time period. Kentucky had a NAS incidence of 13.2 per 1,000 live births in 2011. This has led states like Kentucky and Tennessee to make NAS a reportable condition, or requiring cases to be reported to public health authorities when diagnosed. And by the way, NAS births are not surprising to any of you, very, very expensive. They average about 5 to 6 times the cost of a traditional birth. Dr. Desmond mentioned this in his remarks. Heroin is available in larger quantities, used by a larger number of people, and is causing an increasingly large number of overdose deaths. Heroin is most available in the Northeast and areas of the Midwest. And according to the DEA, heroin seizures in the U.S. increased 81% over the 5 years preceding 2014. I was sent an email yesterday, by the way, where DEA has just designated heroin and prescription drugs the biggest drug threat in America. More heroin is entering the U.S. through the southwest border, and Mexican traffickers are expanding eastward with sophisticated transportation and distribution networks for black tar heroin, and I mentioned that earlier. Beyond greater availability, increased purity and lower cost, a hit of heroin is around $10, have also played a role in the growth of heroin use. Heroin use is growing at a faster rate than any other drug of abuse, almost doubling between 2007 and 2013, from 161,000 to 289. As I mentioned, heroin overdose deaths have nearly tripled since 2010, with 8,200 of our fellow Americans dying from heroin overdoses in 2013. So from 2002 to 2011, a person who had misused opioids was 19 times more likely to start using heroin than someone who had never misused opioids. More than 3 out of 4 people seeking treatment for heroin dependence were exposed to opioids before they started to use heroin. And more than 7 out of 10 people who reported past year heroin use in 2008 to 2010 also reported using opioids non-medically in the past year. So while men are at higher risk for both heroin and prescription opioid overdoses than women, the difference in risk is especially sharp with heroin deaths. Prescription opioid death rates in 2013 were 5.9 per 100,000 for men and 4.4 per 100,000 for women. In contrast, heroin rates in 2013 were 4.2 per 100,000 for men and 1.1 per 100,000 for women. People who die from heroin overdoses tend to be younger than people who die from prescription opioid overdoses, while the rates of death involving heroin have increased for all age groups and races and ethnicity groups. Adults aged 25 to 34 continue to have the highest rates. And for prescription opioids, as you know, the 45 to 54 is the highest age risk group. So there's growing interest in understanding why some prescription opioid users are initiating heroin use and whether strategies aimed at curbing inappropriate prescribing contribute to this initiation. To some, heroin use might be considered a long-term adverse consequence of exposure to prescription opiates. That said, only a small fraction of people shift from non-medical use of prescription opiates to heroin. One recent study estimated that it was as low as 4%. And nonetheless, this is an area that more study is needed. In fact, CDC has a RFA out on the street right now trying to help disentangle some of this. What we do know is that heroin death rates are going up everywhere. This analysis by Rose Rudd and colleagues at the CDC, heroin deaths are going up across most states, while prescription opioid-related deaths are increasing in some states, decreasing in some states, and stable in others. So if the hypothesized pattern held, heroin deaths would be going up most in the states with the largest decrease in opioid deaths. And as you can see by the red bubbles, that's really not the case. FDA and CDC released a vital signs report in July of this year that takes a closer look at the trends behind the growing heroin epidemic. I hope you saw this. The vital signs reports are monthly publications that CDC puts out where Dr. Frieden wants to spotlight one critical public health issue. Nearly all, or 96% of people who reported heroin use also reported at using at least one other drug during the past year, and more than half were using at least 3 other drugs. The people most at risk of heroin abuse or dependence include non-Hispanic whites, men, 18 to 25-year-olds, people with an annual household income less than $20,000, and Medicaid recipients, and of course the uninsured. But most striking, heroin use was found in groups with historically low rates of heroin use, including women and people with private insurance and higher incomes, and the gap between men and women, lower and higher incomes, and people with Medicaid and private insurance has really narrowed in the past decade. Finally, people who abuse or are dependent on prescription opioid painkillers are 40 times more likely to abuse or dependent on heroin. This is another recent occurrence. Fentanyl is a synthetic and short-acting opioid analgesic and is 50 to 100 times more potent than morphine. It's a drug that's approved for management of acute or chronic pain associated most frequently with advanced cancer. Although prescription fentanyl can be diverted for misuse or abuse, most cases of fentanyl-related mortality and morbidity is linked to illicitly manufactured fentanyl when it is laced with heroin or when it's sold as masquerading for heroin. In 2013, there were 84 fentanyl-related deaths in Ohio, and in last year, preliminary data from the Ohio Department shows 502 fentanyl-related deaths, an almost 500% increase. These deaths accounted in 2014 for 20% of all drug overdose deaths in the state of Ohio, compared to just 4% in 2013. And the issue is not isolated to the state of Ohio. We recently issued at CDC a health advisory which provides information on the growing number and widening geographic locations of states which have dramatic increases in fentanyl-related overdose deaths. Reports of state fentanyl drug seizures indicate a significant increase around the country in recent years, from 600 seizures in 2012 to over 4,500 in 2014. And preliminary data indicate that fatalities have increased most in states reporting the largest increase in the number of fentanyl seizures. And as I mentioned, CDC is in the process of working right now. We just had a team that got back from Ohio. They spent the last 3 weeks, so the 3 weeks in late October, early November, doing an EpiAid where they're trying to sort of disentangle and understand the fentanyl outbreak in Ohio better. So as we think about our prevention work, there are really 2 groups of people with 2 very different sets of needs. First, We need to help people already dependent on prescription opioids or heroin. Here, improving access to medication-assisted treatment and other treatment modalities is important. Expanding access to and training for administering naloxone is essential too. Naloxone is an opioid agonist. Second, we need to stop people from becoming dependent on these drugs to begin with. Here, addressing the problematic opioid prescribing that continues to fuel the epidemic is really our critical path. It also requires enhanced collaboration between public health, law enforcement, and other stakeholders. So in summary, overdose deaths from prescription drugs and heroin are at epidemic levels in the United States. We have a better understanding of the drivers of the epidemic and the importance of addressing prescribing. A multifaceted and multi-sector approach is needed to achieve more progress, and interventions must be evaluated to determine their effectiveness and the need for state-specific action. So I hope I've given you I hope I've fulfilled my requirement of setting the context for the day, and I'm happy to answer any questions you might have of me. Thank you very much. Please. I'm not familiar that work is happening, but it's a good, reasonable question. So maybe there's others in the room who have that answer to the question. I'm not sure of work that's happening linking that. Yes, hi, good morning.
I come from a really small local health department on the other side of the state, and we've been trying really hard to work with our local hospital and getting some data and monitoring what's coming in and out of the emergency room. Is there a way that CDC can help us make those connections? Because for some reason, hospitals are a little reluctant to share information out of their ERs with local health departments. I hear chuckles, so I'm not the only one.
Yeah,
that makes me feel better.
We have built out a health system and state support team to do exactly some of that work. And in fact, later this afternoon, I'm going to talk a little bit about some of the work we're doing, Matt Gladden and colleagues, in syndromic surveillance, where they've developed essentially SAS code that can be run on discharge notes, doctors' records, et cetera, that can really, in more real time, flag hotspots of overdose use, and also as well as EMS runs and administration of naloxone, so that states can better target their prevention efforts. Also this afternoon. Okay. Also this afternoon, I'm going to have a chance to talk to you about our Prevention for States Cooperative Agreement Program. We're funding states, 16 states right now, $875,000 to do a whole variety of things, including some of the hot spotting. So we're trying to make better linkages in state health departments. We've only gotten funding for 16 states. We stood up the program in September of this year. We're looking to expand that program. Both the House and Senate mark and the President's budget for this fiscal year that we're in right now, that's the budget, as you know, still hasn't been passed, has increases. So we're looking to expand that program to a larger number of states. And that's some of the connections between state health department, local health departments, and health systems are what we're hoping that program can help enable. Michigan is not one of the currently funded states, I'm sorry. Hi, good morning.
While I'm walking to you, I just wanted to make a note that the chat function is not working on the webcast, so if people have questions, email them to uminjurycenter@umich.edu and we'll read them aloud.
Okay, I have a question, which I think is a very interesting one that we need to think about. I think there is a percentage of people that are getting off of opioids by using marijuana, and I think that needs to be a future focus for the CDC. Especially, you could look at the states where it becomes legalized. So I'm just interested if you have any perspective on that.
Sure, there's a major initiative at CDC right now that's cutting across all of the 13 centers to look at marijuana usage. So the division that I direct also has all of our motor vehicle injury prevention work. So drugged driving is an issue, both from an opioid perspective and a marijuana perspective. It's a very valid concern and point of sensitivity. So we are beginning to think about not not necessarily the transition from opiates to marijuana, but the whole issue of marijuana and its impact on health across a variety of outcomes. So thank you for that.
I think to keep us on schedule, I'll stop it there, in part
Great.
because I know we'll have you back up this afternoon
Great.
so people can hold questions for you then. Thank you very much.